You are staring at a high-energy, lower extremity trauma in the bay. It is high stakes. The anatomy is completely unforgiving, and the mechanical requirement to eventually bear full weight makes this reconstruction incredibly difficult.
Oh, absolutely. It's a massive challenge.
Right. So today we are pulling from a really robust stack of clinical literature. Papers from Francel, Godina, Yarmchuk, who we're going to break down the exact clinical decision-making for mangled extremities.
Yeah, that's the goal.
Our mission for this deep dive is to walk you through the Bellevue management algorithm, the precise timing of soft tissue coverage, how to manage massive bone gaps, and basically how to salvage below-knee amputations when things inevitably go south.
And here's the key point right out of the gate for anyone managing these cases. I mean, this is a marathon.
Yeah.
It's a grueling process of serial debridements, rigid fixation, and getting the sequencing wrong early on will invariably cost the patient their leg.
Right.
But before we even start planning a flap or, looking at donor sites, we have to make the single hardest call in the trauma bay. Do we actually commit to saving this leg?
That is the defining decision. And looking through the literature, the first major trap we fall into is relying way too heavily on the Gostillo-Anderson classification to make that call.
Right.
Because orthopedics uses constantly to guide their antibiotic prophylaxis and basic fracture management.
Exactly, yeah.
We see a grade 3B or 3C open fracture, and we think we have the complete picture. But for you, as plastic surgery residents and attendings, that classification is just clinically inadequate.
It absolutely is. I mean, the Gostillo system just lacks the three-dimensional nuance we need for soft tissue reconstruction. Think about it. A grade 3B fracture with 3 centimeters of periosteel stripping is vastly different from a 3B with an 8 centimeter segmental bone defect. Or, 12 centimeters of exposed tibial cortex with massive crush necrosis across all 4 muscle compartments.
Right, but on paper, they get the exact same label.
Exactly. It simply does not accurately predict our reconstructive requirements, the vascular demand, or really the patient's long-term prognosis.
So we have to look past the orthopedic label and assess the actual biological reality of the limb. And this brings up a really tough question about our own surgical egos.
Oh, for sure. The hero complex.
Right, because we have the microsurgical skills to cover almost any defect. But are we sometimes forcing a salvage that leaves the patient with a painful, chronically stiff, totally useless limb just to prove we can do it?
Yeah, that's the trap.
We really have to check that hero complex, because the definitive goal is preserving a limb that is ultimately more functional than a prosthesis. If we cannot achieve that, a primary amputation is just the superior choice.
That is the hard truth of reconstructive surgery. And when you look at the outcomes data, it's heavily polarizing. Francel's data, for instance, showed a 93% limb salvage rate for grade 3B fractures.
Which, on paper, that sounds like a massive surgical victory.
Right. But when you look at the functional outcomes, it is grim. Only 28% of those salvaged patients ever returned to work.
Wow. Only 28%.
Yeah. They're dealing with chronic deep infections, cold intolerance, persistent neuropathic pain, severe joint stiffness. Compare that to 68% of patients who underwent a primary below-knee amputation and returned to the workforce.
So the amputees are getting back to their lives, their jobs, their independence at more than double the rate.
Exactly.
They bypass the years of external fixators, the multiple trips back to the OR for bone grafting, and, frankly, the heavy opioid dependence.
They do, but, you have to balance that clinical reality with the psychological reality found by Rodriguez and Laughlin.
Right.
They surveyed patients who went through that exact grueling multi-year process of limb salvage, and over 90% of them stated they would do it all over again just to avoid an amputation and keep their native leg.
Even knowing the immense pain and the functional limitations.
Even knowing all of that.
The psychological attachment to the native limb is just incredibly powerful.
Yeah.
But from a purely clinical standpoint, we cannot ignore the absolute and relative contraindications to salvage, the most critical one being the loss of the tibial nerve.
Right.
Like if you have a completely transected tibial nerve that cannot be grafted, you are left with an insensate plantar foot. And that is a massive red flag.
It changes the entire algorithm. I mean, insensate foot essentially acts like a severe Charcot neuropathic joint in a diabetic foot. Without protective sensation, the patient cannot feel the microtrauma of daily ambulation. They develop silent, catastrophic ulcerations the second they start bearing full weight.
Right, so you get chronic wounding, osteomyelitis, vasomotor changes.
Yeah, and you almost always end up performing a below-knee amputation 3 or 4 years later anyway, after dragging the patient through agonizing and expensive reconstructive failures.
Okay, so let's assume the tibial nerve is intact, the patient has good vascular inflow, and we commit to salvage. The clock is now ticking. Once we hit the trauma bay, the sequence of the initial assault is everything.
Yep.
We follow the Bellevue algorithm, life before limb.
Always.
We run the standard ATLS protocols.
Yep.
If the patient is hemodynamically unstable from massive intra-abdominal bleeding, or say they have a severe traumatic brain injury, a fast guillotine amputation of a mangled extremity might be the only prudent choice to save their life.
Survival always comes first.
Yeah.
But once the patient is hemodynamically stabilized, we run into the golden rule of the trauma bay. Stabilize the skeleton first.
Right.
The order of operations here is completely non-negotiable. And it is such a common pitfall for junior surgeons. You look at a severely ischemic, pulseless foot, you see the severed posterior tibial artery, and your instinct as a microsurgeon is to sit down under the scope and do the vascular anastomosis immediately to restore flow.
You do not do it.
Do not do it.
Right, because if you do that delicate vascular repair before the bone is rigidly fixed, the orthopedic team is going to come in right behind you to reduce that fracture.
Exactly.
It's like trying to flawlessly weld a highly pressurized 2-millimeter pipe while someone else is actively swinging a mallet to shift the foundation of the room. The mechanical sheer force of them reducing the tibia will literally tear your microvascular repair right off the vessel wall.
That is exactly what happens in real life.
Yeah.
You will lose the anastomosis every single time. So if the leg has severe ischemia and you're brushing up against the warm ischemia time limit, put a temporary intravascular shunt in.
Right. Just flow down to the foot.
Yes. Then step back and let ortho pin the bone. Get the external fixator on, establish rigid mechanical stability, then and only then do your definitive vascular work.
And once you do establish that reperfusion, you must be hyper-vigilant about compartment syndrome.
Oh, absolutely.
And here's where the clinical picture gets really deceptive. A lot of practitioners assume that if you have a massive grade 3 open fracture, well, the leg is automatically decompressed itself.
Right.
The skin is wide open, the muscle is visible, so the pressure must be gone.
That is a dangerous limb-threatening assumption. A traumatic laceration or an open fracture absolutely does not equal an adequate therapeutic fasciotomy.
Right.
The deep fascia can still be incredibly tight around those swelling muscle bellies. You have an ischemic insult followed by reperfusion, the capillary permeability skyrockets, fluid third spaces into the compartment, and the tissue pressure quickly exceeds the capillary perfusion pressure.
So venous outflow shuts down.
Exactly. Which causes more swelling until arterial inflow eventually collapses too.
And clinically, we're looking for pain out of proportion to the injury, pain on passive stretch of the toes. But in an intubated polytrauma patient, you just cannot rely on a clinical exam.
No, you can't.
We need objective compartment pressures. We are looking for an absolute pressure over 30 millimeters of mercury to mandate a 4-compartment fasciotomy. Or we use Allen's rule, the pressures over 40 millimeters of mercury lasting for 6 hours.
Right.
But honestly, the morbidity of a fasciotomy is incredibly low compared to the devastating morbidity of ischemic muscle necrosis. If there's any clinical doubt, release the compartments.
Precisely. Just be aggressive with the release.
Yep.
So the bones are pinned, the vessels are flowing, the compartments are fully released. Now we face the soft tissue envelope. And massive soft tissue avulsions are notorious for tricking even experienced attendings.
Oh, you're talking about the avulsion trap.
Yeah.
You look at this massive, thick flap of skin and subcutaneous fat that basically got peeled back off the fascia like a banana peel by the tires of a car.
Yeah.
It's still attached to the proximal base. It bleeds a little when you score the dermal edges. It looks viable.
It does.
So the initial instinct is to vigorously wash out the wound bed and just suture that massive flap back down over the exposed bone.
And that is a guaranteed biological failure. Think about the mechanism of injury. That tissue absorbed massive, crushing shear force during the avulsion. The delicate perforators that supply the subdermal plexus have been stretched, torn, heavily contused.
Right.
Progressive thrombosis of that microvasculature is already happening at the cellular level, even if the skin still looks pink on day one. Over the next 72 hours, that entire massive flap of fat and skin is going to declare itself a necros.
It turns black, it liquefies, it breeds bacteria, and now you have a giant infected necrotic mess sitting directly over your exposed hardware and bare tibial bone.
Total nightmare.
Yeah. So the clinical move here, and it always feels terribly radical to residents at the time, is to aggressively discard the fat. You excise all of that traumatized, avulsed subcutaneous tissue, then you harvest the overlying skin from that discarded flap as a split-thickness or a full-thickness graft, and you reapply it to the clean, vascularized wound bed.
It is a radical defatting, but it saves you from a disastrous trip back to the OR for a washout and hardware infection.
Yeah.
Now, speaking of going back to the OR, let's talk about the timing of definitive flap coverage. When do we actually bring in the healthy, vascularized tissue to close the defect definitively?
This is one of the most heavily debated topics in reconstructive literature. Historically, Godina established the classic rule: early coverage within the first 72 hours yields the lowest complication rates and the highest overall limb salvage success rates.
Right.
And the biological rationale makes perfect sense. You get in, you radically debride the zone of injury, and you cover the exposed bone with a well-vascularized free flap before the inevitable bacterial colonization can organize into a mature, impenetrable biofilm.
And that was a gold standard for decades. But let's bring this into the modern era. Yaremchuk's work fundamentally challenged the rigidity of that 72-hour clock. Yaremchuk argued that the adequacy of complete serial debridement matters significantly more than an arbitrary time limit. You cannot safely cover a wound that still has questionable contoothed tissue simply because the 72-hour window is closing.
Right. And let me push back even further on the strict adherence to Godina's rule, because the advent of vacuum-assisted closure devices, the VAC, completely changed our preoperative optimization.
Totally.
Does the VAC actually buy us more time to ensure the bed is perfect? Or are we just using it as a crutch to delay the inevitable need for a complex free flap?
Well, it is a phenomenal tool, but it's a double-edged sword. To understand its role, you have to look at the mechanism. The VAC doesn't just suck fluid out.
Right.
It provides macroscopic strain, physically drawing the wound edges together, and more importantly, it provides cellular microstrain. The negative pressure physically deforms the cytoskeleton of the cells in the wound bed, which triggers mechanotransduction pathways.
Oh, wow. So it upregulates VEGF, stimulates angiogenesis.
Exactly, and it promotes incredibly robust granulation tissue while keeping the bacterial count in check.
So it effectively shrinks the three-dimensional volume of the wound and optimizes the bed. But we cannot just slap a VAC on a massive 3B fracture with exposed cortex and leave it on the trauma ward for a month, hoping it will magically heal.
Absolutely not. And this is where Howe's data is critical. Howe demonstrated that while the VAC is excellent for temporizing the wound and optimizing the bed, pushing its use past 7 days significantly increases your risk of deep infection and ultimate amputation.
Because the prolonged presence of the sponge over bone eventually acts as a foreign body nidus.
Exactly. The core surgical principle remains: early, aggressive serial debridement, followed by definitive soft tissue coverage the moment the wound is truly clean and healthy.
Okay, so we've run the marathons of washouts. We have a clean, perfectly debrided wound bed. Now we have to climb the reconstructive ladder and physically fill the defects.
Yeah.
We classically break the lower extremity down into thirds for soft tissue coverage. For the proximal third, right below the knee, the absolute workhorse is the gastrocnemius muscle flap. It has a highly reliable blood supply from the sural arteries. You can use the medial or lateral belly, depending on the defect, and it swings right over to cover the proximal tibia or the knee joint beautifully.
It is incredibly robust. Moving down to the middle third of the tibia, the local options shift to the soleus or the hemisoleus flap.
Right.
If you only need a moderate amount of coverage, you split the muscle, take half the soleus on its minor pedicles, and leave the rest behind to maintain some plantar flexion function for the patient.
But wait, let me stop you there and push back hard on this local flap strategy for high-energy trauma.
Yeah.
The literature is shifting away from this.
Yep.
In a high-energy Gastilo grade 3 crush injury, isn't that local tissue, the soleus or the gastroc, usually sitting right smack in the middle of the zone of injury? We're relying on muscle that just absorbed a massive kinetic impact.
You are hitting on the fundamental flaw of local flaps in severe trauma. You are absolutely right. The muscle might look intact, it might not be physically lacerated, but the microvasculature is heavily contused.
Right. It suffered interstitial bleeding and edema.
Exactly. When you go in, dissect out that traumatized soleus, divide its minor pedicles to increase its arc of rotation, and swing it into a defect, you are pushing compromised tissue past its physiological limit. The distal tip necrosis rates are unacceptably high.
Which is exactly why, in modern practice, we are seeing a massive shift toward perforator flaps and free tissue transfer from completely outside the zone of injury.
Yes.
We bring down an anterolateral thigh flap, a rectus abdominis or lithosymus dorsi. We bring in completely fresh, uncompromised, highly vascularized tissue to a compromised bed. It provides a much more reliable biological envelope.
It is the safer, more definitive bet. And when you move down to the distal third of the leg, down by the ankle and the distal tibia, that debate is moot. The local options simply vanish.
Yeah, there is no local muscle bulk to rotate down there.
You are staring at tendons and bone. The distal third mandates a free flap.
Okay, so we execute the free flap. We have a beautiful, healed, soft tissue envelope.
Yeah.
But what about the underlying skeletal architecture? We can't just leave a 6-centimeter diaphyseal void in the middle of the tibia and expect this patient to ever walk again.
We cannot. But here is the critical sequencing rule for bone defects. Delay the bone grafting.
Right.
A common pitfall is trying to place a bone graft acutely into a recently contaminated high-energy wound at the time of initial flap coverage. Do not do it.
Yeah, you must get your soft tissue coverage first. Let the free flap heal for 6 to 12 weeks. Let it establish a highly vascularized, sterile, robust envelope.
Yes.
Once that biological reactor is primed, then you go back in, elevate the flap, and address the bone gap.
That biological sequencing makes total sense because non-vascularized bone grafts rely entirely on creeping substitution. Osteoblasts from the surrounding tissue have to migrate into the graft matrix. If the surrounding tissue is a vascular scar, the graft just resorbs or gets infected. You have to give the new bone a highly perfused bed to live in.
So how do we size the different orthopedic solutions once we are ready?
It scales entirely with the size of the defect. For segmental gaps under 3 centimeters, the orthopedic team can usually pack the defect with non-vascularized cancellous bone graft, typically harvested from the iliac crest.
Okay.
Because the defect is small and the new soft tissue bed is rich in blood supply, it incorporates very well. But for gaps between 4 and 8 centimeters, the biology shifts. You are looking at Ilizarov distraction osteogenesis.
Right, and when ortho does an Ilizarov distraction, we know the basic mechanism. They perform a corticotomy on the healthy proximal bone, wait through a brief latency period, and then slowly pull the bone ends apart via the external frame at a rate of about 1 millimeter a day.
Right. The tension-stress principle generates new, healthy woven bone in the wake of the distraction.
But for us, as plastic surgeons, the reconstructive nightmare is managing the soft tissue. We have to ensure our newly healed free flap can tolerate that continuous, daily mechanical shear force and stretching over months without tethering to the advancing bone, tearing, or thrombosing its pedicle.
It requires meticulous planning and often secondary procedures to release the tethered flap. Now, what happens when the defect is massive, say 10, 15, or even 20 centimeters of the diaphyseal tibia is just gone from a shotgun blast or a massive extrusion?
I mean, distraction osteogenesis would take years for massive gaps up to 24 centimeters.
Yeah.
You have to bring in vascularized bone. We use the vascularized free fibula flap.
Yeah.
We harvest the central portion of the fibula from the patient's healthy contralateral leg, along with its peroneal artery blood supply. We bring it over, inset it into the tibial defect, and microvascularly anastomose the vessels so the bone is instantly alive. It doesn't have to rely on creeping substitution. It heals like a primary fracture.
It is an elegant operation, but you must absolutely remember the strict anatomical and biomechanical rule for the fibula harvest. You cannot just take the entire bone from the donor leg.
Right.
You must leave exactly 6 centimeters of fibula intact proximally at the knee joint and 6 centimeters distally at the ankle mortise.
Because the fibula plays a critical role in stabilizing those joints, particularly the lateral collateral ligament at the knee and the syndesmosis at the ankle.
Exactly. If you violate that rule, you severely destabilize the healthy donor leg, causing chronic pain and instability, which is a disastrous, entirely preventable iatrogenic complication.
So let's fast forward. We execute everything perfectly. Rigid external fixation, a beautiful ALT free flap for the distal third, a delayed free fibula to bridge the bone gap.
Sounds great.
But this is the real world. Complications are still going to happen. The hardware gets infected. The distal foot dies from lack of macrovascular flow. When things go south, the reconstructive strategy shifts immediately from anatomical restoration to functional salvage. Let's talk about the nightmare scenario, chronic osteomyelitis.
It is the ghost that haunts every trauma surgeon. Chronic osteomyelitis happens in about 5% of severe open tibial fractures, even with perfect early coverage.
Right.
The bacteria wall themselves off in a mature biofilm on the necrotic bone cortex. Systemic salve antibiotics simply cannot penetrate it. The treatment has to be ruthless.
Yeah, you have to go back to the OR and perform a radical oncologic-style debridement of all the dead and infected bone until you reach healthy, bleeding punctate cortex.
Exactly.
Once the dead space is surgically clean, you immediately bring in another well-vascularized free flap, often a muscle flap like a lacusimus, to obliterate the dead space and bring the systemic antibiotics right into the core of the tissue bed.
And with this highly aggressive approach, the success rate for eradicating the infection is actually excellent, around 80% to 95%.
But what if the bone is clean, but the foot itself is completely unsalvageable? The tissues are necrotic, the vascular runoff into the pedal arch is totally gone, but the knee joint above it is still perfectly functional and intact.
Then the clinical mandate is crystal clear. Save the knee at all costs. You perform a below-knee amputation or a BKA.
And we need to explicitly state why preserving that knee joint is so profoundly critical to the patient's biomechanical future. It comes down to the massive physiological energy expenditure required to walk with prosthetics.
Yeah.
Walking with a below-knee amputation requires roughly 25% more energy than normal native walking. It is taxing, but highly manageable for most patients. But if you have to amputate above the knee, an above-knee amputation requires 65% more energy to ambulate.
It's a huge jump.
Yeah, that physiological toll completely alters the patient's quality of life. It limits their daily walking distance, their independence, and their ability to navigate stairs or uneven terrain.
It is the difference between a patient walking independently in the community versus being largely wheelchair-bound.
Yeah.
So if we are doing a below-knee amputation to save that joint, we frequently encounter a major problem. What if the soft tissue around the proximal tibia, the area we need to use as the amputation stump, is completely destroyed from the initial trauma? How do we cover that exposed tibia so the patient can actually bear weight in a rigid prosthetic socket?
This is one of my favorite techniques in all of reconstructive surgery. The foot fillet flap.
Oh, it's brilliant.
If the foot is dead from an orthopedic or vascular standpoint, but the extremely thick, specialized plantar skin on the bottom of the foot is still intact and viable, we do not throw it in the biohazard bin.
Never.
We literally strip the bones out of the foot and use that plantar tissue as a pedicle or free flap to cover the exposed tibia on the amputation stump. It is the ultimate surgical upcycling.
Yeah.
We're taking viable, high-quality parts from a discarded amputated limb to build this incredibly durable sensate shock absorber for their new prosthetic.
Upcycling is exactly what it is, and the biomechanics of plantar skin are unique. It is glabrous tissue. It is biologically engineered with specialized fibrous septae to bear the entire weight of the human body and resist massive, repetitive shear forces.
Right. Whereas standard skin grafts or muscle flaps break down quickly inside a prosthetic socket. Plantar skin does not.
And, crucially, when we perform the foot fillet, we can carefully dissect out the tibial nerve from the foot flap and coapt it to a cut sensory nerve in the tibial stump.
Which provides critical protective sensation.
Exactly. The patient can actually feel the pressure of the prosthetic so they don't develop silent, catastrophic, full-thickness ulcers inside the socket.
It is a brilliant, highly functional salvage technique. Now, are there any other extreme salvage situations attendings need to be prepared for? What about vascularly compromised patients who suffer a trauma?
Oh, you see this in patients with severe pre-existing atherosclerosis. You might evaluate their mangled leg and initially think microsurgical limb salvage is impossible because there are simply no healthy recipient vessels in the zone of injury to plug your free flap into.
Because the arteries are basically decalcified pipes.
Right, but you can perform a simultaneous vascular bypass.
So you work directly in tandem with vascular surgery. They drop in a synthetic PTFE graft to bypass the diseased calcified vessels from the popliteal down to the distal leg, effectively revascularizing the extremity.
Yep.
Then you step in and plumb your microvascular free flap directly into that brand new synthetic PTFE graft for its arterial inflow.
The operative time is massive, the physiological stress on the patient is intense, but it is a masterclass in multidisciplinary salvage that can save a leg that would otherwise be inevitably lost to ischemic gangrene.
It requires flawless coordination, but it works. So what does this all distill down to for our daily clinical practice? Lower extremity salvage is the ultimate surgical marathon.
Absolutely.
It requires perfectly timed, ruthless serial debridements. It requires rigid skeletal fixation before delicate vascular work. It demands highly creative, biologically sound soft tissue coverage, prioritizing uncompromised free tissue over traumatized local muscle.
And we are constantly working in lockstep with orthopedic and vascular surgery to preserve functional length, prevent deep infection, and ultimately get the patient back on their feet with a limb that serves them better than a prosthetic.
Before we wrap this deep dive, there is one piece of literature in our stack we haven't touched on yet, and it might eventually upend this entire algorithm.
Oh.
We talked earlier about the transected tibial nerve and the insensate foot being a massive red flag that usually forces our hand toward amputation. But Trumbull's pediatric nerve graft data showed real, measurable promise for returning both motor strength and protective sensation to severely traumatized lower extremities through advanced grafting techniques.
Yeah, that data is fascinating.
Right. So as microvascular nerve repair technology continues to evolve, it begs a fascinating question. Will an insensate foot always be a definitive absolute reason to amputate? Or will we soon routinely wire sensory nerves directly into our lower extremity free flaps, completely restoring the functional feedback loop, preventing neuropathic ulcers, and keeping those legs off the amputation table for good?
That is the future we're heading toward.
Just something for you to think about the next time you are standing in the trauma bay looking at a mangled extremity.